So we're going to hear a recording from Dr. Theresa Tam. She did it yesterday afternoon and sent it to us last evening. She was named Canada's Chief Public Health Officer on June 26, 2017, and I'm sure she probably didn't imagine where that appointment would take her. She's a physician with expertise in immunization, infectious disease, emergency preparedness, and global health security. So as Canada's Chief Public Health Officer, Dr. Tam is the federal government's lead health professional in relation to public health. And in this role, she provides advice to the Minister of Health. She supports and provides advice to the President of the Public Health Agency of Canada. And she works in collaboration with the President in the leadership and management of the Public Health Agency of Canada, another structure that was put in place post-SARS. So the Public Health Agency of Canada Act, a piece of legislation, empowers Dr. Tam as the Chief Public Health Officer to communicate with all levels of government, voluntary organizations, the private sector, and Canadians. And I know we've all seen and heard from her on public health issues. But each year, the CPHO is required to submit a report to the Minister of Health on the state of public health in Canada, and that's legislated and due about 6 months after the end of the fiscal year, so in the fall time of each year. So Dr. Tam is going to speak to us today about the report that she tabled in October of 2020. And Maricia is here from the Office of the Chief Public Health Officer, and she can answer questions after Stephen's presentation. Theresa Tam, Dr. Tam's presentation is about 16 minutes long. Early in the presentation, she speaks in French, and if you check the chat box, we will provide a translation for the English speakers there. But she really talks to the opportunity to examine in these conversations with all of us together, to really examine the larger repercussions of COVID-19 and all of us together to take measures to address those repercussions. So Danielle, if you can play the recording now, that would be great. And please use the chat box as you're listening to Theresa Tam. Thanks, everybody.
Good afternoon, everyone. Bonjour à tous. Before I begin, I'd like to acknowledge that artwork where I'm delivering these remarks is located on the unceded territory of the Algonquin and Anishinaabe Nation. I would like to thank the Algonquin people for their stewardship of this land. I'd like to thank the National Collaborating Center on Determinants of Health for their leadership in taking the CPHO annual report and creating a knowledge mobilization series. Il s'agit d'une excellente occasion de discuter des répercussions plus vastes de la COVID-19 et de prendre des mesures à cet égard. Cela nous permettra également de nous attaquer aux inégalités structurelles historiques au sein de notre société qui font courir de plus grands risques à de nombreux Canadiens. Merci à Dr. Claire Becker et à son équipe pour la vision et les actions prises. Just to kick off the webinar series, I have this opportunity to share with you some of the key findings from my annual report on the state of public health in Canada, called From Risk to Resilience, an Equity Approach to COVID-19. As all of you know, our health greatly depends on our social and economic well-being. And collectively, we must do better to protect our most vulnerable. This pandemic has jolted our collective consciousness. Many people in the general population now understand the importance of protecting those most at risk with social policies and economic supports. We have seen some incredible structural changes during this pandemic at a speed that is as unprecedented as the pandemic itself. My goal is that we maintain this momentum to expand and sustain structural changes so that our populations are better prepared for future health emergencies. Like all of you, I remain deeply concerned about how the pandemic has exacerbated existing inequities in our social, economic, and health systems that have resulted in some populations disproportionately bearing a heavier burden of the effects of the virus. While the COVID-19 pandemic affects us all, we all know that the risks have been worse for many groups, including seniors, workers who provide essential services, racialized populations, and people living with disabilities. Previous research on epidemics and pandemics show that the morbidity and mortality across populations are shaped by differences in exposure, susceptibility, and treatment. This framing integrates biological risks and underscores that structural inequities have put people in harm's way. Equity matters, not only to those who are unjustly excluded, but to all of us. Because as some populations are disproportionately impacted, the risk of the virus spreading impacts all of us. There are overlapping and compounding risks related to sex, gender, racialization, housing, and other socio-economic factors which may place some people at greater risk of exposure to COVID-19. For example, women have experienced a disproportionate impact of COVID-19, but immigrant and racialized women have been particularly vulnerable due to the frontline nature of their employment, as well as their gender, citizenship status, race, and/or class. So I'll never forget some of the really poignant stories of workers in long-term care facilities who are not well paid, may not have good sick leaves, holding down more than one job in more than one facility or homes or healthcare settings in order to make ends meet. And they're often women who are racialized, and they are an increased risk for contracting the virus, but they are also inadvertently an increased risk of spreading the virus to others. And some of the deaths that have occurred in healthcare workers have been in this group. So that is an extremely sort of in-your-face example of these differences that are borne by different populations in Canada. So as you can see now on this next slide, that there have been many broader impacts of COVID-19 and the public health measures that help to control its transmission. An incredibly challenging aspect of this pandemic is balancing the need for public health measures while recognizing that the impact of these measures come at a great cost. Many of these impacts are exacerbated by health inequities, and there is a risk that they can have long-lasting effects after the pandemic. Upon reflection, it strikes me that COVID-19 is about human relations. The virus passes from one contact to another. As humans, we want and need to connect with each other, and as we do, we are driving transmission. This is what makes this pandemic so hard to keep under control. For example, we are seeing that a major consequence of the pandemic is the worsening of the opioid crisis. Travel restrictions and border measures continue to disrupt supply chains, making the street drug supply of opioids susceptible to contamination and toxicity. Pandemic restrictions may also mean less access to services and supports, including social connections. So we've heard some really tragic stories of people who are dying alone at home. Their colleagues who normally would see them on a day-to-day basis don't see them as often because some people are teleworking, for example. So people are looking in on each other. Those social connections have been disrupted, putting people at risk for dying from the opioid crisis. So what I had hoped with the annual report is to provide a look at the evidence on what kind of structural changes can be helpful in improving health in the context of the pandemic. On the slide, what's illustrated are some of the high impact areas for action. And in the report, you'll find some concrete examples that can be implemented and in our work to level the playing field during and after the pandemic. And this includes employment protections such as access to paid sick leave and other benefits, safe and affordable housing through programs like Housing First, and ensuring equitable access to digital health services. It also calls us to simultaneously address stigma and discrimination. Throughout the COVID-19 crisis, it has been striking the structural changes that recognize the social determinants of health as fundamental to the social and economic security of our country. And a great example of this is that we have needed virtual care for years, and in the last few months, there's been sudden change and support for digital access to health services. We need to sustain some of this momentum to maintain the important gains made and to strengthen resilience that comes with equity in the face of future emergencies. So in the past, we developed Canadian pandemic plans, which are mainly focused on the health sector. I've certainly been very much engaged in pandemic planning that included other sectors. But we need to actually do that intersectoral planning way better. So it's extremely clear, I think, as the pandemic evolved, that our pandemic efforts in preparedness, planning, and response has to be reimagined with a much more robust intersectoral approach. This has to be driven by evidence, which have been summarized in the report. And at the sort of end chapter of the report, I'm calling for action in 3 key areas. First, we need to sustain cross-sectoral leadership and governance, which has been tremendous throughout the pandemic response to support the structural change. We need to ensure that we're collecting detailed, stratified data, which can tell us which communities need greater investments. And when combined with strong health equity measures and indicators, we could have a broader definition of risk that includes understanding and reducing the social and economic risks that make some populations more vulnerable. I see it is really important to address this between pandemics and regularly review and practice our pandemic and health emergency readiness. Second, we need to harness the power of social cohesion as a key ingredient to coming through this pandemic intact. It takes everyone to adapt to the COVID-19 crisis. Communities that trust their governments have strong norms of taking care of each other. So both a trust in government and taking care of each other can better control epidemics and pandemics. This requires action at all levels, from transparency and authenticity of leaders to communities having trusted information and leadership over data and decisions. Lastly, we must have a strong and robust public health system. During the response, there have been significant investments in key areas such as lab data and surveillance, contact tracing, personal protective equipment, and rapid research. We must also fill longer-term gaps such as accessible and intersectoral data priorities and multidisciplinary research. Public health cannot do this alone, and relationships need to be stronger across sectors and disciplines so we can surge and adapt during a crisis when maintaining capacity to address ongoing issues. I'm just sort of going to use a very timely example just very quickly to illustrate what we have to do in these 3 areas. So everybody knows right now one of the really key public health measures is the deployment of safe and effective vaccines. For that to have happened, to get vaccines in under a year required massive intersectoral collaboration, not just from the scientists who discovered the vaccines, but from the private sector who has to develop and manufacture them, all the researchers who do clinical trials, the regulators working overtime to ensure that the vaccines are authorized are safe and effective, even giving the very rapid timeframes. public health systems that have to get themselves up and running in order to develop these vaccination programs, all the logistics and communications. But it is about trust in leadership, trust in government, and good ways of addressing mis and disinformation that's going to increase that societal cohesion and boost vaccine confidence. Because after all, it's just not just vaccines that saves lives, it's vaccination that saves lives, putting the needle in someone's arm. So imagine how much of that leadership and societal cohesion and trust is needed to get a successful vaccine programs underway. And as we have to prioritize vaccines in short supply, it's really incredibly important to take an evidence-based approach that takes into account equity. Who is at the highest risk of severe impacts, and who may be at the highest risk of transmitting those at the greatest risk of serious outcomes. Those are the kind of prioritization approaches that the National Advisory Committee on Immunizations and the provinces trying to take to make some of these difficult decisions. And none of this can take place without community engagement, including with First Nations, Métis, and Inuit leadership and communities. So really, I just want to end by saying that no one is protected until everyone's protected. And that is not just for Canada, but for the world. This is a pandemic, so a global public health crisis. So we have to continue to work together in order to address the pandemic and the inequities that underpin our society, so that we can move from that risk base to resilience and build a better, healthier nation for all Canadians now and beyond COVID-19. On the website, and you'll find a couple of supplementary reports which attached to the my annual report. One is a What We Heard report highlights, which is a really collection of stories and themes heard from discussions with First Nations, Inuit and Métis leaders, scholars, organizations and communities about the impacts of COVID-19, as well as resilience and innovation during the pandemic. The second report summarizes the proceedings from a virtual Best Brains exchange, which brought together federal, provincial, territorial, policy and decision makers, researchers and implementation experts, non-governmental organizations and other key stakeholders to better understand the intersectoral COVID-19 impacts on the health and well-being of priority groups in Canada to inform the design of protective strategies moving forwards. And you should be able to find these reports very shortly on our website. So really, lastly, I just want to extend my deepest thank you to all of you who are participating in this webinar. Your commitment, resilience, and ingenuity over the last year. You have all been part of this massive effort that the public health community across the country has undertaken in standing up this pandemic response. So thank you for all that you've done and will continue to do for Canadians during these uncertain times. And I'm really looking forward to the discussions that will unfold, and looking forward to some report back on what has taken place over the course of this webinar series. And looking forward to engaging with all of you to address inequities during COVID-19. So thank you. Merci. Have a good webinar.
Well, thank you, Theresa. Thank you, Dr. Tam, for those, I think, very inspiring messages. And so, Marie, I'm going to ask if you'll bring that back to her. So a couple of things that really struck me, and then we'll move on to hearing from Dr. Stephen Hoffman, is equity matters. We can do something about this. Her final statement, Theresa's final statement, that no one is protected until everyone is protected. And I really appreciated her example around vaccines and a prioritization of populations in terms of vaccines and our vaccination effort that'll that'll be happening or is happening. And really asking some pretty straightforward questions around who's at risk, who are we not thinking about, who might we want to consider in terms of risk, who can we consider?